So welcome to Pediatrics, NUR203. My name is Professor Bogart. I am currently working on my doctorate, my PhD. I was one of those crazy people at the age of 53 decided I needed higher level degrees. I was an associate degree nurse forever, and I never wanted in my life to have any regrets. So at age 53, I went back up my BSN, my MSN, and because of COVID, and I have a really bad autoimmune condition, I have rheumatoid arthritis, and I'm on infusions, that COVID really knocked me back, that I couldn't go out and do a lot of my research. So I'm going to see what I can do to get that done. But I literally have all the training for PhD at this point. But I'm Professor Bogart to you. I came to Fortis and it was my first teaching on ground. I had done a lot of clinicals and I've always been mentors for all the nurses, all the younger and older nurses at my job. I've always been that resource person that anybody could go to and I would never say no and I would always help. I came to Fortis in 2017 and I taught pharmacology and pediatrics. I have worked both in the adult and pediatric world. It's a very unusual thing for nurses. They usually choose, I just want adults or I just want pediatrics, and they usually don't mix. So half of my career was in adults. I did adult open heart, ER, surgical ICU, medical ICUs, cardiac ICUs. And then I switched over into pediatrics. Newborn ICU, pediatric ICU. My favorite of all favorite places is the pediatric cardiac intensive care unit, which I opened at our area hospital down here in Miami, where I'm located, with Dr. Burke, who came from Boston, and we're now an internationally world-renowned center. So I opened that with Dr. Burke many years ago. And I love cardiacs. I can see blood pumping in my head. I'm really weird. I see the heart, I see things going wrong. And I think I can describe to you these conditions by the way that I understand them. I just think of everything as a garden hose and a kink. And we know if we have a kink, it's going to squirt or pop somewhere, right? So that's the way I think about blood flow. So we'll get into that when we get there. My last 10 years at Nicholas Children's, which was the big pediatric center here, is working in the emergency room. And I think that's really given me the background that I need to teach pediatrics. I've seen most of the conditions I'm going to talk about. And how did I deal with them? How to assess them? What do I need to do? And I'm going to try to get you thinking, okay? That's my job. Next semester, most of you are going into capstone. And right now you're learning information, you're memorizing. Well, I'm going to take you away from that memorization. I'm going to make you think a little bit. So how am I going to do this? Well, what I ask you all is when you come to class, look through the material. Now, you don't have to do an in-depth reading, studying craziness, okay? I will be sending PowerPoints usually by Friday or Saturday for the next week so that you can look over the PowerPoints, look at them, see what I'm going to go over, and then I'm going to do the PowerPoint with you. And I'm going to talk to you and I'm going to try to explain it. And I'm going to give you so many stories of patients, parents, siblings, things that I've seen in my career that'll help you understand these things. Then I'm going to do a Kahoots. Now, I spend a lot of time updating PowerPoints and updating Kahoots every single semester. And how do I update these? Well, at the end of every course, you all have a essay. That essay gives me information and it shows me those areas, those concepts you are weak on. So what I'll do is make sure that I have it in my lecture in the PowerPoints, and that I also give you something on a PowerPoint to make you think about it. So if you've done your little work before you come to class, then you listen to my lecture and then you do the PowerPoint. This is 3 times you've heard the same information. And we know repetition makes you understand it better. The one thing I ask from all of you is if you're not understanding something, I don't care, stop me. Professor Bogart, I don't get that. Stop me, because I am sure somebody else doesn't understand also. And I love questions, okay? So never be afraid. I'm never offended. Please, please ask me questions. I do not mind. Stephanie, I'm going to need your last name on your Zoom, and I also need your camera on, please, Stephanie. And if you don't, I've been told to kick you off class, and then you won't get credit for class. So please turn on your camera. All right, so what are we going to do today? Well, pediatrics used to be a 2-hour class. We're going to be running about 2.5 hours. Which what means what? Well, I know that in ground class, you need to be there on time, and then you get 10 minutes per hour per break. So that's about 20 minutes. So I will be ending classes usually about 10 after, quarter after 5. I'll run straight through and get you out a little bit earlier, okay? It's better than you leaving, coming back, and I'll be hitting you with the PowerPoint first and the Kahoots, and then you're also going to find that we're going to be doing the quizzes in class now. They're not going to be you at home doing quizzes. And I'm going to go over that when we get to the next PowerPoint, when and how we're also going to do those things. So let's go ahead and share, and let's start with our nursing online PowerPoint, talking about what do you need to know, and what and how are we going to score you, how are we going to do the quizzes in class this semester and from now on. I mean, if you're on ground, you're doing a quiz every class when you start the class. Well, we're going to be doing that also here online. And then I'm going to talk about attendance and what you need to do for me. And I want you to succeed. So, talk to me, communicate with me. I'm going to be that person you need to reach out. And I'm telling you, I want to know before something happens. You communicate with me and I will work with you, okay? I'm not this big bag meanie of a professor. I do listen and I want to know what's going on. And I'll tell you where my restrictions are and how I can help you. So something's going on, you can't get something in, let me know, okay? And I will work with you. So we know online learning, you think you come to class, it's online and it should be very casual, but treat it like you are on ground, okay? So come in to the classroom, keep your cameras on, they can't be pointed at the ceiling. If you need to eat, go ahead, please eat. I understand you guys are busy, you have families, you work, you need something to eat. I don't care, it doesn't bother me. I have my big jug of water next to me, it's okay. Have a drink, it's not a problem, okay? Whatever you need from me, all you need to do is ask. If you're not understanding something, please send me a message. I'll come before class, I'll stay after class, whatever you need, please let me know. And if you're running into issues, and let me tell you, I've heard so many things. I started the pediatric online program and I actually wrote how we're going to do it. So I've been here since the beginning of pediatrics with Dean Brown. So what do you do, and who to contact? Well, I am the lead pediatric professor, so I am the person you should try to talk to first. I'm the instructor and I am the lead, okay? Now, if you can't get what you want from me, please, please contact Dr. Brown, okay? I do not mind. You're not rattling on me. You're not tattletaling. No, if you need something, I'm not responding. I want you to contact Dr. Brown to let her know where your frustrations are. And I won't be offended and I'm not going to take it out on you or anything of the sort, okay? So let's alleviate those sort of fears. Just talk to me first. Now, Darlene Brown, or Dean Dr. Brown, this is her email. Look at it carefully because usually it's like for me, bbogart@fortiscollege.edu. Hers is darlene.brown. there actually is another D Brown in Fortis somewhere. So she will not get the email. So we found that out early. And that is her phone. Leave a message. If she doesn't answer it right away, that means she's at another meeting. Remember, there's 3 national deans. She's one of those. So she's quite busy. My cell phone, you need to get a hold of me, and it's something you're having a heart attack about, you need to know as soon as possible, text me. It's 305-951-8055. And it's on my, welcome page. So it's already posted there. And, I usually will answer up to 8 or 9 o'clock at night. Sometimes I go to sleep earlier, who knows, but I do answer quite quickly, you will notice. I think that, you have concerns, and sometimes this is the only time you could get your homework done, or you have this question and you can't get back to the work for 2 or 3 days. I understand that. So I try to get to you as quick as I possibly can. So contact me first. If you can, just message me on Canvas, send me an email. I've got it in my phone, so I've always have my phone next to me. I'm always checking it. So, it's become one of these obsessive compulsive things, always check the email, making sure those students have, the answers to their questions. And again, if you need to me, please text me or call me, okay? Texting is actually better than calling me, because I don't always hear the ringer. So when you're here online, I just want you to remember that we are like in a classroom, to be courteous and positive. I want you to wear clothing that's not, revealing, showing, be comfortable, okay? But remember, other people are looking at you, all right? Try to, if you're, talking, to try to talk in proper language, don't use slangs. And, this was said here about that netiquette is don't message me in all capital letters. I feel like you're screaming at me. I didn't know what that meant until somebody told me. I'm like, yeah, I guess it sort of appears that way. So online and attendance. Now, this is a little bit of changes that are going on. Online attendance will start at the time it's designated. Now, this class is from 3 to 5:30 p.m. Eastern Standard Time. Some of you are in Central. So you should be here by either 2 o'clock or 3 o'clock, whatever your time zone is, okay? Make sure you're on time. As I said, I usually wait 3 minutes, okay? That usually seems to be people are going to come, that they'll be in here by then. If you are 5 minutes and later, I have to take off 15 minutes of time from you. Now, how does this become important? Well, if you come in late and you leave early, you're losing time every week. I will let you know when you are 5% of your total time is not attending, 10%, 15, and 20% means you get a full letter grade deduction on your grade. So if you had a B plus, you go to a C plus. If you had a B, you're at a C. So you could fail the course just from attendance. You have to treat it like online. So how do I take attendance? Well, I have the Zoom. Zoom gives me the chat box. Remember, I need everybody's full legal name in the chat box with your campus. And then I compare that to the Zoom log and the Zoom chat log. And I give attendance every single week. Now, the other thing with attendance is you getting into Canvas and submitting work. Now, this week, what do you have? Well, you've already done the technology quiz and the book, ebook, et cetera, et cetera. That shows already that you've been in the book, and it actually shows attendance. This week, there is a discussion question, and the first post is due by Wednesday. I usually will send you a message on Thursday if you have not posted it yet to remind you. I would prefer if they're in by Wednesday, and then you give the 2 peer reviews by Sunday, but I understand sometimes you forget. As long as it's all in there and you've done it as well as you can. Remember, it is APA format. Remember, I want a reference. I want you to cite within the body of the paragraphs, where did this information come from? And I do read them. I like to hear what you have to say. This first one talks about, why do you want to be a nurse? And I've heard all different things. It could have been your child was sick, your mother was sick, grandma was sick, or I always wanted to help people. I mean, I always knew from 6 years old I wanted to be a nurse. And it's all I ever wanted to be, and nothing ever changed. I mean, maybe it was a doctor sometimes, and I realized I can't afford to be a doctor, so I guess I'll just be a nurse. And it's been the best thing I've ever done. And actually, I'm a doctor anyway, right? So what's the difference? Now, every single week, make sure you go in and you check that Canvas shell several times as you can, okay? And see if there's any announcements that are there that you need to take care of as soon as you can. I will be getting everybody's phone numbers, so if it's something urgent, I will text you and let you know who I am, okay? Late work policy, and I do follow this pretty closely. You need to have your work in by Sunday, 11:59 Pacific time. So for some of you, Eastern time, that's going to be 2:59. So, just remember that it must be in by that time. Now, if it is late, you have one more week to turn it in, but you will have a 10% deduction on it, okay? After 2 weeks, so you're supposed to turn it on this Sunday. Next Sunday, you didn't get it in, you cannot turn it in anymore, and you will get a 0 for that section of that homework or the subjective grades. Our class is 80% of all of your key graded assignments, which is all of your HESI, your quizzes, and your exams. And then all the homework subjective grades is 20%. And that 20% can fail you. And I've seen it, even one again last semester in one of my classes, even with many, many, many reminders. And I will remind you, please get your homework in. Please get your homework in. So I'll work with you to try to remind you. So to be counted in class, sign in with your full names, have your camera on the whole time. Anyone who is at work or driving or sitting in a car will be removed from now on, okay? I saw one person in a car. I'm not removing you today because you're getting what's going on here. So, but from now on, I have to remove you, okay? So I will be, like I was calling out for somebody to come on camera. If you don't come on, I have to remove you. This is part of, I've got rules I have to follow too. So I'll try to work with you. Something's going on with you, message me. But if you were in class, you would have to be there on camera, right? Because there is no camera. You would be there in front of class. Now, as I said, 15-minute increments, you'll be, I mean, if you're 5 minutes late, it's 15 minutes. If you leave 2 minutes early, it's 15 minutes, so be very careful, all right? You will be notified if you're getting close to that 20% and getting a deduction, a grade deduction, okay? And again, remember to post in Canvas, which means make sure you do your homework. At least 2 places you need to have something touched in Canvas. If not, they could drop you without notification. I mean, we do try to notify you. Say, I don't see anything posted here. Please post your NCLEX questions or do your discussion question or do your case study. I will try to remind you. So again, we're talking about the attendance policy. It's basically what I've just said to you. Not only am I looking at it, we have the registrars looking at it, and also the secretary of Dr. Brown. This is her baby this semester, making sure she's following up, making sure students know if they're starting to get higher in the percentages of late time. So please, if you have to be absent for any reason, remember, if there's a quiz that day, you do not get to take that quiz. It's gone. There's not a makeup on it. And quizzes for this course now as I said, are going to be inside the class. The first 2 quizzes I'm going to do at the end of the class so that you can see what the quizzes are, and you're going to be able to see what you need to study, what you need to look at or pay attention to during class, so that we're not just hitting you with, hey, we're going to just do quizzes, and they're all brand new quizzes, okay? Just to let you know. Again, just like I said, full letter deduction, 20%, and you'll know at 5, 10, and 15% what's going on. So it will be absolutely no, like, oh, I didn't know that was going on, because you'll be notified. So how are you going to be successful? Well, students do it in all different ways. There's students who program stuff on their phone, some that just use Canvas, some use a scratch piece of paper every week. What do I have to do? Or they take the syllabus and they'll, scratch it off when they're done. Whatever it is, keep yourself organized. Many of you, as I said, are in 3 courses. Med-Surg 2 is a bear. But pediatrics is a bear too, because remember, this is high level medical knowledge that you have to apply to children. And it's a little different than adults. But I will tell you when there's the similarities, because as I said, I've worked both pediatrics and adults. So I know the differences there. Again, read the instructions. For instance, the first set of NCLEX questions that are due are all on growth and development. And there's a separate section in your Saunders NCLEX, okay? So if it's not growth and development, I'm going to tell you, you get a 0, please send it back to me, okay? So again, to be successful, let me know what's going on. Make sure that you are here, that your computers are charged or that they're plugged in. If you're on an exam with me, make sure your phones are charged or plugged in. And, I know many of you are at home, you have children around you. Make sure that you have a quiet space that you can pay attention as much as you possibly can, so that you can listen and understand. Again, log in 4 to 5 times a week. Make sure you know what's going on. And again, those announcements, I usually will post your recordings by the next day. So I do have a YouTube channel. It is Professor Bogart's Pediatric Nursing. And I have all of last year's recordings there. And I'm going to repost again and continue to post on it. So you will see your the recordings there. I have exam reviews there. I have a dosage calculation review there that makes dosage calc so easy. In fact, if you need dosage calc help, I'm the person to ask. I can make it simplified, okay? So again, make sure you get assignments when they're done. You get sick, you can't lift your head off a pillow, you're admitted to a hospital. Let me know before things are due. Send me a text message. I'm in the hospital. My homework ain't getting done. All right, I can work with you. If you tell me after, I've got to give you 10% deduction. Okay. So again, day 1, go into Fortis, look at it, make sure that you have my name, program my phone number into your phone so you have it there at all times. Okay, so that you know how to get a hold of me. The syllabus is the final. That's exactly when things are due, okay? So if you're confused, the syllabus has when things are due. And make sure that you have your books and that you confirm that they're also there. As I said, come to class ready to discuss things, and you're going to see how I teach. I'm going to be doing the first week's PowerPoint. I'm also going to be doing a Kahoots today. So you're going to see my method of teaching to try to help you, so you'll know what you need to look at before you come in. And, this is not a bad book. Actually, it's a really good book, and I find it easy to follow. Many other places. I know some are over the head. Well, that's when you come to me and say, hey, I didn't get that. Could you explain to me what that means? Because I know. I will meet with you whenever I can. If you need extra help or you don't understand something or you want to do an exam review, whatever you need, please send me a message, and between everything I have to do, I will work a time that works with you. I'll fit my schedule into yours. If you're finding, let's say you did evolve and the grade didn't go over, number one, of course, message me, but remember there's a help ticket. Send a help ticket in, and they're actually pretty quick getting back information to you to get things that you need done quickly, but also let me know too. Now, I don't do weekly review sessions, but I will be staying after class to answer any questions anybody has about anything. So if you need to talk about anything, I'll be there. And again, I will be here to do one-on-one tutorings whenever you need. I know that students which had weaknesses, for instance, last semester, I had one student who got all dosage calculation questions wrong. And the first exam, and she could have had a 90. So she ended up with an 80, at least she passed. But the second exam, she got them all correct. And it's because she came with me, we sat down, and I made it easy for her. So it does work, and you can get better scores by coming in. Now, this is right off the syllabus. It tells you what things are due. There is, unit exam, quizzes, HESI. Those are 80% of your grade. The rest is 20%, and your clinical and sim are both a pass-fail, okay? Your case studies open a week before they're put into your syllabus. So if you have, for instance, let me get one. The first one that you have due is burns, and it's due for week 3. It opens on Monday of week 2, and it will be open for 1 week later, okay? So that will be, if anybody doesn't get it done on time, I will minus the 10% and you can do it by then, okay? NCLEX questions. I didn't put any time that you can start them, only when they're due by and when they're late by, okay? So NCLEX questions, you can do them over and over and over again to get the grade you want, not a problem. Case studies, it's 1 attempt. So when you do your case studies, make sure that you are getting the grade that you do want. The dosage calculation worksheet is in Calculate with Confidence. You can start working on that. And it does help you with your calculations on your exams. I will be giving you examples of what to expect for dosage calc on your exams in pediatrics. There is no mics per kilo per minute in pediatrics, okay? There's heparin and there's mLs per hour and then mics per kilo dosage calculation type things. Now, the big thing that's going to be due is a pediatric assessment, and that's not due till week 8, and it's 6%. And the one thing about pediatric assessment, you can start on it anytime you want, because by week 8, you're going to be up to here in homework, and you're going to be a little bit crazy, and you're going to not know, your head from your foot. It gets very busy in the end. So you can start working on it sooner. So what do I ask from you? I want to know what you are going to choose for your pediatric assessment project. And it's a 3-fold thing. It is a 250-word APA paper. Tell me about the diagnosis. What is it? The second thing is a pediatric assessment form, which is on your modules right now, okay? I'm taking it and expanding it, but I don't think I can do that till next semester. But it's an assessment form. Tell me what the kid with that diagnosis is. If you're talking about a child with asthma, I don't want to hear the respiratory clear lungs. I want to hear there's wheezing, expiratory wheezing, retraction, nasal flaring, grunting, whatever, okay? And then the third thing is a teaching. teach nurses, and I've done this for real life, taught nurses, had my students teach nurses on diagnoses they had not heard about. Could be a different syndrome they had never heard. So that's something. But mostly students, what they do is they'll teach either the child or the parent. And it could be a PowerPoint, 5 or 6 slides, nothing crazy. It could be a picture board or a brochure. Remember that the brochure and the paper both must have references and a minimum of 2 on each of those, okay? If you hand them in early, I will review them and tell you, if you do this, I can look at it to give you a better grade. So it behooves you to hand it in early, not to wait till the end, okay? I want you to understand what you're doing, and I want you to enjoy this because it could be fun. Pick something that you have, your child has, your neighbor has, your brother, your sister, your aunt, something that you want to know more about. Make it more personal and do your virtual child that way. Pick an age, but make the assessment fit the age and the diagnosis of what you're talking about, okay? Any questions with that, let me know. So I have all the homework grades turned off right now, but on week 6, I turn them on. And that will show you how positively or negatively the lack or you're doing those assignments can affect your grade. On week 8, I turn it back off. And you will not see it until after the HESI, until everybody has done the remediation, and then I turn them on. So that will be on week 12, usually Tuesday afternoon. It'll come back on because week 12, Monday by midnight is when all the remediation will be done, okay? So that's when you'll know. So I can't turn it on for one student. It has to be for the whole class. So exams, quizzes, HESI, you must have a 78.0 or higher, and then you can turn on your homework grades. Remember, I told you homework grades can fail you, so be very careful. Try to get the best grades as you possibly can. Students do miss quizzes, and that's 1% of your grade. Your NCLEX questions are 1.25% of your grade, each single one. Each case study is 1%. So it can add up to be a lot of percentages, all right? So quizzes. Quizzes are part of your KGA. And we, again, this semester are going to be doing during class. So what I'll do starting next week is your first quiz. I will be teaching a PowerPoint. Hopefully you'll come to class prepared with questions or looking at the PowerPoint, understanding a little bit, maybe looking at your book, opening it a little. Come to class, listen to lecture, then do the Kahoots with me. And remember, my Kahoots all take care of concepts you're going to see on exams, on quizzes, and on your HESI. These Kahoots are good to use for HESI preparation too, because I make sure every week you'll have everything you need. And you'll know at the end, I will put all your Kahoots posted on announcements. I'll put all your exam reviews on the announcements and the PowerPoints for you to look at. So you have all the information you need to be getting that 99.99 on the HESI, because you can. If you do the work, you can do that in this class, because I am making sure your concepts are covered. And if you're not understanding, you didn't ask me a question, okay? So I know that you can do well. I know right now, I think HESIs, for me, my mean HESIs are well over 900 for 100 students. So we're doing pretty good. I've been doing this now since 2017. So this is my 6th year of making sure that I'm taking care of my students and they understand what they have to understand and know. The quizzes will be done, as I said. Quiz 1 and 2 will be at the end of the class. They'll start at 5 o'clock. And you have 15 minutes, they're timed. You only can go forward, you can't go backwards, okay? If you come to class, you listen, you participate in the Kahoots, and a lot of you get very competitive on who's going to win, okay? You will do well on the quizzes, okay? So, but only the first 2 quizzes I do that way. Quiz 3, 4, and 5 will be at the beginning of class when you come to class. So at least you'll be able to see, what do I cover? What do I need to know? Exams are through ExamSoft, and make sure you come with your Zoom. Make sure you have a whiteboard. I do not want a piece of paper and a pencil. Whiteboards, get them at the dollar store. They're actually pretty cheap. Or take a baggie, put a piece of white paper in it, and a dry erase marker, and you just erase it as you go. I've seen students do that too. But at least you can erase it at the end of the exam, okay? You will not get exam grades until Friday night. That's the hardest thing about being a Monday class. My last class in pediatrics ends at 10:30 Friday night. So I need all of the exams in. And why do I need that? Well, some questions may not be asked correctly, or they could have made some confusion. And sometimes we throw some of the questions out. So if I have all of the courses, every single section has been done, I'll have an accurate overview of what questions we need to look at more carefully, okay? So you won't be getting them till later on. I mean, some of you I know are paranoid and have anxiety and, oh my God, I can't wait. I can say you're okay. That's all I could tell you, but I can't tell you more than that, okay? At least I could do that for you. Again, exams are 1 attempt. I've had students where their internet cuts out and they're gone. Now, don't worry, that exam is not lost. We can set you up later, but immediately text me, immediately message me in Canvas or an email. My internet is gone. You know, I was on question 12 in the exam. I can restart the exam for you. So don't worry. Even when you're doing exams, if they don't upload right away, don't get upset. Don't worry. I can get the exam grades and your exam 2-3 days later. It doesn't get lost, okay? Don't worry about it. But if you're uploading and it doesn't upload, you just shut down your computer and restart it. It's usually the best way. And usually by then you could be able to take it and download it and you'll be fine. And I usually will tell you, I will let you know if I'm not getting your exam grade, and I will let you know so that you can do whatever, or we need to call ExamSoft and we could do that together also. Again, exams are timed. Anybody who has any special allocations and time, I need to know before exam 1, because I need to set you up differently. So anyone who has extended times, and there are several, let me know. Because if I have you in class coming at the time of other students, you're going to run later. And I do teach after the exam. Okay, I will be doing a PowerPoint or a Kahoot or something to teach you that information. So I don't want to not give you class time that you need to understand what are the concepts, okay? So exams, the accommodations I said I need to know, and I need to know before, which I said I need to know as soon as you can. Exams are always during class times. Now, very important. The only time it is not on the scheduled class time if we have approval from the dean. Has to be something going on. You have documentation. There's many things that have occurred that we've done it, but you need to let me know before they're scheduled, okay? So I need to know as soon as you know I can't do the exam that day. Again, Zoom, make sure you're on camera. I do check your ID. Again, make sure you don't have earplugs, you don't have iPhone watches on, et cetera, et cetera. Exams that are missed, remember, they are 10% deduction unless I know before and I have approved that you're not going to take your exam on that day, okay? And I do need that documentation because my dean will be asking for it. And it's basically what I just said already here. Again, if you're working on the quizzes during class time, you're working on the exams, something's going on, internet, something happened, you got booted off, just notify me immediately. I can tell on the quizzes, I can reset them. On your exams, I can reset them. So please, again, communicate with me. I can help you. I can't help if I don't know, okay? And I want to know as soon as you know. Again, your syllabus is the Bible. That's what we followed through. Make sure you're organized and make sure you do your assignments as quick as, not as quick, as well as you can. Get your best grades. You could take a C+ and make it a B if your homework assignments are done, you know, in the right way. And I'd rather have a B than a C+. I mean, I use one of these, you know, little weekly things, monthly things on my desk and write things in for me. But, you know, I'm sure all of you are going to use your phone and set your reminders, etc. I'm just not that technology person like you all younger people are than me. Again, the late policy, went over it once, turn it in on time, you get full to grade. After it's late for only 1 week, it's minus 10%. After 1 week, we will not accept it unless there's some extenuating circumstances. And again, I need to know before it's due. NCLEX questions must be submitted in the proper fashion. I will not accept them if they're not done properly. If I'm finding you're just giving me like that screen up there, that little green square that just said completed, I will not accept it. I will send you instructions on how to do them. And I do look to make sure that you've done the areas that are appropriate and your modules tell you which sections to use for pediatrics. Again, as I told you, the first one is growth and development. It's not under pediatrics, it's a separate headline there, okay? Again, NCLEX scores, you can do them over and over again. I don't need remediation on NCLEX questions. Just do your score where you want to have your score. Each set of NCLEX questions is 50 questions, and there are 4 of them, and they are worth 5% of your grade. So each one is 1.25% of your grade. So make sure that you get them in. They do count quite a bit. Case studies, go through the modules. You cannot go directly to Evolve because you will get a 0. Make sure you go through the modules and it's 1 attempt only. As I said, it's open the week before it's due and a week later for those late people, okay, that are going to get the minus 10% deduction. So try to get them in on time. I do send reminders, usually on Sunday afternoon. I'll sit and send reminders to make sure, but try to be cognizant of that also. So let me see. Go through the course modules, and there are some special circumstances, but you know, I've not hit one yet where they had to go through Evolve themselves. All of the case studies will link immediately to your grade book. If you see after you do it and it links over into your grade book, it's a 0, you need to let me know and send a help ticket. If you don't have the help ticket, I will tell you how to get there, okay? So the paper and discussion questions. Remember, these are APA format, which means what? It means that you need references, you need to cite your work, and it should be double spaced, and it should be written in a manner where you're telling me information without cutting and pasting from a source. Okay, so make sure when you do these discussion questions, don't just cut a whole thing from some source and put it on the sheet. I want you to try to give it to me in your words. What does that mean? Always follow the rubric. Now, on your assignment for your pediatric assessment project, there is a rubric. Make sure that you do APA and you do the 3 sections. And as I said, turn it in earlier and I can send it back to let you know what you can do to improve your grade, because 6% is a lot. It's a lot of work. Use work that's less than 5 years old. You can go get nursing journals. Sometimes you go into websites. As long as you are telling me where you got things from, I'm okay. I mean, you're associate degree, be associate degree graduates. I'm not as particular as a bachelor prepared student, but I do need to know where you get things from, and I will help you make it better, so that as you go forward, and many of you will go on in your education for your bachelor's and master's, and who knows, PhD like me. No, do a DNP, don't do a PhD. DNP is actually makes more sense to me now. I just didn't know better. Exams and quizzes, again, we are going to go class. We're going to go through the modules, and we'll get there. And again, they'll be opening at 5 o'clock for quiz 1 and 2. And then you'll have 15 minutes. Again, technical problems, please let me know so I can help you. Now, HESIs. HESIs are given once in pediatrics. These are given on week 11. Most of them are on campus. I've had only 2 campuses last semester that did them in Proctor U. I have no control when your campus is going to do your HESIs. So as you get closer to HESI date, ask your deans, your assistant deans, when are we going to do the HESIs, when the schedule is coming up. After that, I will be given reviews on your exams, on your HESI. Each one of the pediatric professors will be doing a review, okay? During the exams, we have one PowerPoint we use, and you know, every person explains things a little differently. I highly encourage you to see at least 2. Look at mine and look at someone else's. Someone that you can understand the way they explain things, and it will help you be successful and help you pass. And remember, these exam reviews are also good for your HESI, okay? So something to go back and to refer to right before your HESI. After your HESI, you will be doing remediation, and it's the same hours like you've been doing all along. I will not put your HESI grade into the grade book until the remediation is done. And I every day do check the site to see if your remediation is done. If it's getting close, I'm going to send you personal messages. Please, you only have 2 more hours. Please get it in. Because if you don't do remediation, you get a 0. Again, exams, I do look at IDs. Again, keep yourself on camera. During the exams, I will have no talking, any communication, even resume codes. We do it all in chat, and we do it very seamlessly. I work very well keeping you informed, and so that other students don't get like, can you imagine you're sitting concentrating on a question, all of a sudden a student starts talking. I think I would jump and I would lose all trains of thought. So out of respect, we don't talk during exams. So remember, when we're teaching here, we're teaching you how to be almost like a nurse, expectations that are due. If we have a medication that's due or a treatment that's due on a patient, we want it done in a timely fashion. And that's why there are times that we have to have done, and that professionalism and, talking to each other in online, on Zoom, in messages. So just remember, you're all going to be RNs, and that's amazing. And you've all done a lot of strides to get there. So you should be all proud of yourself to get to this point, because I know you've all worked very hard. So that's a great thing. So any questions about any of that stuff? So Anna, remember, next week I can't take you in a car, okay? Just to let you know.
But because I live in Key West and it's my husband right now, sorry. I will change.
Okay, I'm just saying from now on, I can't. This is how, the first one.
I know. Sorry.
It's okay. And Katanya, where'd you go? You need to keep on camera for me.
She put a note in here in the chat that said something is wrong with her sound or her internet, and she's leaving and rejoining.
Okay, thank you so much. I appreciate that.
Do we have class on Monday?
Next Monday is Martin Luther, isn't it?
Yes, ma'am.
No, there is none.
Okay.
So I will be sending you a recording from the Wednesday class. So you will be getting that. Now, how are we going to do your quizzes? I need to figure that out with the dean. Okay?
Yes, ma'am.
I will send you a message. That will be an announcement. Okay? I didn't think of that. Thank you so much.
Got it. Thank you.
All right, let's go to this week's information. Hold on, where'd it go? So this week we have a few chapters we're going over, and I do take and condense it up so that it's not as overwhelming. And then I'll take you and put you into a Kahoot and show you some of the key concepts that, as you're going through and reviewing this week's information, that you should be aware about. So chapters 26, 27, 28, 29, and 30. What do you need to know about them? Well, pediatrics, it's healthcare for children. Now, I didn't understand what healthy people was, but the government has written down goals for different people, whether they're underprivileged, poverty, elderly, the young, and part of Healthy People for Children talked about in 2030, these are the goals that are set. The last ones were 2020. And when I first started doing it was 2010. It just talks about that there's support in the family, that, development, growth and development, mental health. Children do have mental health issues. Nutrition couldn't be the, when you look at nutrition in children, there's nothing more important than nutrition. If you don't have nutrition, how do you grow? How does your mind function? So nutrition, 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 so important. Being at a healthy weight, being active, and oral health. If your mouth is full of cavities and hurts, are you going to eat? Are you going to get nutrition? So think of it that way. Healthy sexual development, activities, adolescence, safety and injury prevention. And this is at any age. We're talking newborn all the way up, even to the elderly, safety and injury. And of course, what's out in the community. So some of the childhood health problems is obesity and type 2 diabetes. We know that today it's a fast food society. Children are eating more fast foods, which are higher in calories. Also, children are there on their iPads, they're there on their computers, they're there on the Nintendo Switch, the new thing. My grandson just got one of them, and I don't even know if it's a good idea or not that he has it. But we have to limit his time. We also know that with obesity comes the chances of type 2 diabetes. So we have to be careful. Now, childhood injuries are a big thing. And when we talk about childhood injuries, probably the place where most injuries occur is motor vehicles. Are they put in the motor vehicle in a seat correctly? Is it front facing, rear facing? Is it in a booster seat, et cetera, et cetera? Violence, gangs, all of this stuff. And of course, all of that bullying in school. And then vaping is one of the newer epidemics that's going on. And as I've already said, mental health is a big deal. Just some pictures to depict some of the things that can go on with kids. Guns, it's usually the older kids, but young kids can get into it. I mean, I live in South Florida. I live in Homestead. I'm about 30 minutes from the Keys, and there's water everywhere. And my little grandson at age 2 could do front flips in the swimming pool and could swim without swimmies on because I was so afraid of this kid drowning. And he still cannot go into my pool without asking, Nana, can I go into the pool, please? And he's never done it. He did it one time. He got yelled at, put on timeout. It scared him, and that was it. So we helped with that, but we still don't not watch them. Have to. Suffocation, leaving medications around. And I even had an older brother who got a big pan of oil from a frying pan down his arm and had all sort of scarring for his life. So very, very dangers in children. Some of the health problems with children are due to different things. Prematurity, very low birth weight, and low birth weight. When you have young kids that are born, their lungs aren't working, their brains are fragile, they're apt to get infections, sepsis. There's no immune system, so that causes a lot of problems. Kids in daycare. I call daycare the place where they swap spit all day long, isn't it? They go from one toy in the mouth to the other kid in the mouth. And is it a bad thing? Actually, no, because what are they doing? They're building up their immune systems so that when they get to school, hopefully they're not going to be as, sick all the time. There are many children living in poverty and are homeless, which creates a lot of problems. They're not eating right, not sleeping right, not bathing right, etc. Immigrant families, they're afraid to get health care. I know that I would see some of the immigrants coming into the emergency room with a child. I was always afraid because I know they'd be very sick because they're afraid that I'm going to deport them. And that's not my job. My job is to take care of the child and get the child well. I'm not worrying about immigration laws, but they don't know that. So they're afraid. So those kids are sick. Children with chronic medical, psychiatric illnesses, disabilities. I mean, these children need multi-complex things to help them to be able just to live their normal life. And then there are barriers to adequate health, dental, psychiatric care. I mean, you say that everybody can get health care. Yeah, well, they got to get there. Do they have transportation? Do they have that $5 copay to walk in the door? Many of them don't. So, and a lot of cultures don't believe that my kid has psychiatric issues. So they're not getting the care they need. Infant mortality. I mean, there's a little baby there. That kid's probably about 600 grams, probably a 25 weeker. You see that nice red skin, it's almost see-through at that age. These children have no immune system, and just some big sounds and movement can cause bleeding into their brains and intraventricular hemorrhages. So a lot of things. And their lungs, their lungs aren't formed. There's no surfactant to hold those alveoli open, and exchange oxygen. So, you know, you're talking about deaths. Yes, the younger children have a higher level of infant mortality. As they get older, their infant mortality decreases, gestational age, and their weight. The low birth weight children have a higher chance of problems and, you know, being, you know, mortality than do the bigger children that are born, you know, on time, you know, 39, 40 weekers. So childhood mortality, death rates for children greater than 1, as I said, can go down because now we have built sort of an immune system. You know, we evaluate them. We know what's going on. But just remember that there are things, safety risks that can cause problems in those ages. You know, you think of the toddler, the dive bomb kids, they have no fear, right? They're going to jump from the couch to the coffee table, miss, and go on the cement floor and bang their heads. And I mean, all different things because there's no fear. There's just no filter on these children. Now, as they get a little older, they're starting to understand they can get hurt. So between 5 to 14, that's the lowest death rate. They're more careful. And then in adolescence, they think they're adults. So they become a little bit more careless with injuries. It could be even sports injuries. They want to be the best at what they can be. So they just get up and go and don't stretch and they think they're invincible and, you know, they could get all these injuries. Homicide, firearms, big thing with these adolescents. And then in adolescence, we're going to learn not next week, the following week, about adolescents, and their whole thing is their identity. You know, it's body image, and a lot of it can cause depression, a lot of emotional turmoil in the adolescents. So suicide is big. So as I said, those increased morbidity or illnesses is the homeless, the poverty, those low birth weight children, daycares, and even children from other countries do have some conditions that, you know, we're not as familiar with. Now, the one thing about pediatrics, and probably the one thing deterrent that stops nurses from going into pediatrics, is you're not just taking care of a child, you're taking care of a family. You're taking care of that mother, overwhelming, you know, needy mother, father. So you have to include them into your care. Now, I've worked with parents and some of the most difficult parents. They love to give me the difficult parents. And I've learned how to get them involved in their care and be my biggest helpers. But it does take a little time. But in the long run, the child gets better care. Remember, family-centered care. What is that? That's what pediatrics is. It's not just the child, it's the whole family. It's the mom, the dad, the grandma, the grandpa, and it's also the siblings at home, right? Everybody, get a sick child, everybody's involved. So the family is their constant in the child's life. It's what they know. That's all they know. They don't know other cultures. They don't know other families. This is especially the younger ages. So we need to address the entire family when we're talking needs. And what is a family? It's whatever they say it is. Is it 2 moms, 2 dads, a mom, a grandma? Is it grandma? Is it adopted? They're all different families. And the family is whatever they tell you it is, because there is no absolute definition that has to be a mother and a father and a child. I mean, that's the old definition. There's just too many of them. Now, pediatric nurses, I think, we're the psychologists for the family. We're that in between that child and in between the child and the physician. And we have to build up a great therapeutic relationship. We want the parents to be able to talk to us so we know what their needs are, their frustrations are, because we're their advocates. We are there to help that child get better. We're there to teach the parents and the child how to prevent diseases and to make sure that they don't get sick. Health teaching, injury prevention. So clinical judgment and reasoning, we need to see what's going on. And we need to take from that, ask questions, and we need to say, what do I need to do for that family? How can I help that child? Because again, it's with the family. Now, in pediatric nursing, we try to provide atraumatic care. Now, I was very blessed that I worked with a hospital system, and I was the nursing research co-chair for our entire hospital and for the emergency room. And I developed a program called Huggies, but it's H period, U period, G period, G period, like the diaper, but I made it a yellow and green instead of the red and blue. And it's helped us give great injections efficiently and safely. So we do pinch kids a lot, as they say down here, pinching. We poke them and there's needles going everywhere. My thing on that was hold your child, give them comfort. They're comforted before. They're not just strapped down on a stretcher and given a shot in their leg, their arm. They're in the mother's arms. So they're gonna have less fear, stress, and pain before, during, and after. And that does help with pain and the fear of coming to the doctor's office, or for nurses, or going to the ER. We can also put spraying creams and spraying lotions and all ice and all different things we can do to help give the child what they need, but giving them the least amount of pain as possible. So that Huggies program still very vibrant and works. And they're into the comfort theorist, all about comfort. So let me tell you, being held by a parent, that is a comfort thing. So it reduced the psychological distress because we didn't have to take the child away from the parent. And the physical distress was less because they're in mommy's arms. And we sort of work around the parent to give the injection so they're not hurting as much. Again, first, do no harm, because what do children get for the first 2 years of life? Immunization, 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 right? We're always giving them injections somewhere. So family, social, cultural, religious influences on children. And it's actually something we need to think about. You know, I came from a little small town, you know, it was I don't know if there was any other cultures but Americans there, you know, and I didn't understand the differences with Hispanic or Haitian or Jamaican or German or what. I just didn't know because I was never exposed to it. So I had to learn. So first thing we need to look at is the structure. Now, for instance, a Hispanic family, the grandma and grandpa are the ones who actually rule the roost many times down here. There's some Middle Eastern families that the father's the one who dictates what you're going to do or who you speak to. So understanding what sort of family they are, and then you know how to treat them, whether they're traditional, they're blended, you know, 2 women, 2 men, 1 man, 1 female, whatever it is, we need to know the structure so that we can help them to understand. So we need to look at what are they good at, what are they vulnerable at, and we need to teach them. Now, as I said, understanding family roles, parental roles, it takes time. And what I have learned is walking into a room, maybe it's a culture I don't know, say, who would you like me to talk to? Who's going to be the spokesperson? And that's going to help so that I have not offended anybody. And I'm telling you, any culture wants me to ask versus just assuming mom knows everything, because it's not always mom all the time. So understanding their cultural, their social, religious influences can help things. For instance, you know, look at cultural. There are some cultures who don't eat meats, has to be vegetarian, or sometimes it has to do with practices on them. the way that they look at you. There are some cultures that don't look you in the eye because it's respect. There are some cultures that do like cupping or rolling pennies or quarters on them. And sometimes I actually was involved in one where they took chicken blood and had it and did this little, I don't know what, around the patient. And I was pregnant and they made me put a quarter, tape it to my belly button because they didn't want any spirits getting into me. And that's their culture. I don't have to believe in it, but I have to respect it. And the crazy thing is, one day later, that guy did very well. He was extremely sick. And after they did whatever they did, you could see him get better. So whatever it is, I have no comment. As long as it doesn't hurt my child, cause any harm, it's okay with me. And as long as it doesn't break any hospital rules, okay? So race and ethnicity makes a difference. Remember, there's also, when you talk about poverty and you talk about teaching. Now, if you have a child who doesn't have a lot of money, and let's say they're diabetic, how are you going to teach that child to eat when they don't have that access? So this is something you have to keep in mind, when we're teaching them. Where did they come? That immigration status, just like that immigrants who come down here and work in the black dirts and the vegetables down here, the migrant workers, religion and spiritual identity. I've had children come in, they were from Miami Beach, had a broken arm, and they were some class of Jewish faith. I don't know what, but they couldn't turn the light switches on and off. And the little boy's shoe was untied. And that little boy had a broken arm that we had to set. So I had to work within them and say, the other girl in the triage said, he can't tie his shoe today. She was Jewish. I don't know. So I tied the shoelace for him. These are little things, but understanding that gains a lot of respect from the parents that you're getting that. So being aware, maybe they have to do some sort of religious thing 6 times a day and, do praying, or maybe it's, fitting your schedule within them does help. So a frequent health problem of migrant children and adolescents in the United States is what? What do you think?
C.
Anybody?
Tuberculosis.
It is tuberculosis. Migrant children, they don't get all of the immunizations, they're not as much as required. So yes, that is a big concern. So another thing that we look at is cultural beliefs, is taking care of the child. Now, there are some religions that don't want a male nurse taking care of a female. There are some religions that you don't want to expose their bodies. There are sometimes, again, different diets they want. Also allowing them times to do prayers or working your treatment plans around that child and their spiritual or cultural beliefs. It will gain respect and it makes that child and that family feel better. Because, when you have that mental attitude of feeling better, you're going to feel better, right? One of the things that I didn't understand is working in the emergency room, we had a lot of Hispanic patients here. And we'd have grandma bring in their little, let's say 8-month-old child with a fever, and had a hat on, booties on, 2 onesies, wrapped in a thick blanket, and brings them in, and temperature's 104. So immediately what do? I start taking the hat off, the socks and the booties off, and I start taking off the onesies and the blankie and take the temperature. And I have to explain about this to this grandma who's apparently very active in the child's care, even if mom or dad is there, and explain that if a fever is held in, it's just going to go higher. You have to let it go out. You need to let it go away. Another thing with this hot and cold thing is You know, having a child with a fever, this Hispanic culture believes that you should walk on the tile floors with socks on. You should not go barefooted. And I say, listen, if you have a fever and you're walking on a cool floor, it's going to help decrease the fever. So leave the socks off. The fever can go away. So again, I'm explaining in a way that they're understanding, because I know a kid feels horrible with a fever. And if we give them cool drinks, give them the antipyretics as ordered, not overdress them, not have it 100 degrees in the house because they have a fever. I said, you're comfortable, the kid is comfortable. No socks, no hat, and you'll be fine. And been explaining it about holding the fever and et cetera, et cetera. I mean, I've discussed about voodoo, witchcraft, or whatever that was, but it does work. And there's all sorts of health practices. There are all sorts of teas and herbs. You know, my husband's Jamaican, and his big thing is ginger and garlic teas when you're ill. Remember that there are some contraindications with some of the herbal remedies. We know anything with a G can prolong bleeding, right? Well, what if a child did have issues and was on a blood thinner? You're going to thin the blood more, right? So understanding that it's a possibility will have you ask. Religious beliefs can affect, I think one of the biggest ones with religion I could tell you about that I've worked with several times is Jehovah's Witness. Now, I don't have to believe in Jehovah's Witness. I just have to respect their wishes, right? Part of Jehovah's Witness is they do not believe in giving blood or blood products to them or their children. They feel that it tarnishes their soul. Now, premature infants do not make new blood cells, and they are going to require multiple blood transfusions. Now, I will never make a Jehovah's Witness parent sign a consent for blood. It's against their religion. They feel like they've tarnished their child. So we get a court order and we can give it. Now, am I going to take that blood bag and go like this in front of the parents and show it to them? Oh, no. Now, I did work a lot of night shifts. Actually, 23 years of nights I worked. I love a night shift. I love the autonomy of nights. I could be my own little self and help everybody else all night long. But I would say to the parents, go home. I'll take care of it. I should be done at this time. You can give me a call and I'll tell you if it's okay. And they appreciate that. They respected that. I've also worked day shift where I had to give blood. And I said to the mom, if you could just step out for a second, I'm going to take care of it. And I would do what I want, put all the blood stuff away, no blood bag hanging anywhere. And I'd put a blanket over the IV pump and the tubing. They didn't have to look at it. And the respect you get for being courteous of their feelings, they'll remember forever. And I'm going to tell you why I know that. One of the last days that I worked in the hospital, I had this 18-year-old kid come in, and I looked at the diagnosis and I'm like, I know this kid. And I went in and I took care of him as an infant, and they were Jehovah's Witness. And I had to twice give this boy blood, and I covered up everything. And the mother said, for the last 16, 17 years, she'd been going around looking for me. She just wanted to hug me and thank me for remembering and respecting who she was. And I just was blown away that 18 years later, she remembered me. And little things like this make a big, big difference, okay? And remember, as I said, natural remedies, medicines, there's all different things different cultures take. Just make sure it doesn't interfere with the medical treatment we're doing. There's no reason why you can't combine them as long as there's no contraindications. As I said, remember, nurses are this absolute in-between person. We're the psychologists, we're there. Our goal, though, is to make sure that child gets the best care they can, and to do it in a manner that's according to evidence-based practice and research, and we're doing the best things for that child. So, leading cause of death among African American boys ages 15 to 19 is adolescence. Anybody?
I think it's C.
It is, it's firearms. Yes, it is. Remember violence. Violence in children. They do risky behaviors because they think now they're big enough, right? They're old now. I'm a teenager. Genetic influences, let's see. Well, let's look at growth and development. Now, growth and development, look at an infant, and we're going to talk about this more next week. They start at 7 pounds, they can't lift their head. By 1 year old, they've tripled their birth weight and they're running down the hall and they've got 4 or 5 teeth. It's amazing. It's interrelated, simultaneous, ongoing that happens. Now, these foundations of growth and development, remember, we need to know basically when things are going to happen. And if we see a child isn't where they should be, that we need to have an intervention, whether it's they're 5 months old and they're not rolling over, or they can't lift their head up, or they can't grab anything with their hands. Something's going on and we need early intervention. And those early interventions could be speech therapy, occupational therapy, physical therapy. What's great about kids, you can catch them up really quick. Kids can do more than you can imagine if we catch them early. So, when we talk about growth and development, we talk about, how big are they getting, right? That means at 6 months, they double their birth weight. At 1 year, they triple their birth weight. That's growth, okay? And we can measure that. We can see that. That's why we are going to take a height and weight on every kid when they walk in the door, whether it's in an urgent care, ER, doctor's office, don't matter. We monitor that. And doctor's office plotted on a graph. The development is more, subjective. Are we seeing them turn over, lifting their head? Are they doing grasping? Are they cooing? All of these things. So next week, that'll be something to look at. And then maturation, being able to deal with certain circumstances, and then the differentiation, starting to understanding different, things, moms and dads and, foods and, what do they need? So all of these things, all about growth and development. Now, stages of development, as I said, is those tasks that we're going to go over next week. There's a lot of them. Either growth and development, there's a couple different words that we look at: directional trends, sequential trends, developmental pace, and sensitive periods. And basically, it just tells you that we start with lifting their head and turning over and creeping and crawling and walking. We're talking about being able to, grasp something, whether it's voluntary or involuntary. These are all things that we need to look at the front of the book and look at those words. You'll see them again. So we look at metabolism. Well, I'm going to be sending you a vital sign sheet. The vital sign sheets are going to show you the difference in vital signs on an infant up to a teenager. Do you know that an infant is a normal heart rate of 140 to 160 beats per minute? Normal at rest. Normal. That's at birth. Their respiratory rate is 40 to 60 breaths per minute. So as we get older, the number comes down. So we know you become an adult, heart rate 60 to 100, respiratory rate 12 to 20, right? Normal things. So when we're working with pediatrics, we need to not only look at what the child's going on with the child, but how old they are. And are those vital signs appropriate for that age child? As I said, sleep and rest again, infants sleep a lot, we know that, when infants are born, what do we do with them? We put them right under a warmer, right? They have no temperature control and they'll drop their temperatures quick and we'll roll them up in blankets. As they get older, they need less and less and less of that. Nutrition, 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 single most important influence on growth. You don't have nutrition, they're not going to grow, their muscles aren't going to grow, their brains aren't going to work, and it's going to create a lot of behavioral and developmental delays. And we know kids, we have the easy kid. My first kid was easy, my second kid was horrible, right? It's that easy kid, difficult kid. And then you got those kids who just don't, they're shy. They don't come up to you all that easily. And they're kids. All of them are different and special and unique. And that's why I absolutely love working pediatrics, because you never know what you're going to get. Now, throughout this course, you're going to see about these theorists. We have Freud, we have Erikson, we have Piaget, Kohlberg. We don't really work with Fowler, but we do work with the other ones. I will be going over these in each section: infant, toddler, preschool, and school age, to tell you what these theorists tell you for those age groups. Freud, he's all about oral. Think about an infant. What do? They want to suck, right? They want a pacifier. They want to suck on their fingers. It's all oral. How do they self-soothe? Oral. How do they relieve stress? Oral. It's all about the mouth. It gets up to, and he goes through all the different psychosexual Freud. But first, it's all about oral, then it's anal, that's potty training, right? And then it's phallic, latency, and it goes into genital. And we're going to be going into these as we go into the groups of children. We talk Erikson. Erikson is all about a child and how do they feel. For instance, you have a newborn baby, young baby, less than a year old. They cry. What does somebody do? Somebody goes, grabs them, gets them, changes their diaper, burps them, feeds them, holds them, whatever they want, right? That's what Erikson says. That's the trust. What about that infant who cry, and nobody comes, gets them? That is mistrust. So trust, Erikson, on an infant is all their needs are being constantly met, okay? So we're going to, again, go into what do those things mean. So Piaget is all about figuring things out, cognitive awareness. I'll give you an example. We do just a reflex grip, and then it's called a reflex palmar grip, which means you put something in their finger, they're going to grab on it. Whether it's mommy's finger or whether it's a rattle. Well, as they get older, they can do voluntary. They can grab that rattle. Well, Piaget says they shake it and they hear a noise and they like it. So they've learned something. So now they know if they get that rattle and shake it, they're going to hear that noise. So that's sensoromotor, okay? So it's in the mouth, they touch it, they taste it, they feel it, and then they shake it, they hear noise, okay? So we're going to go into those too. And, we talk about more cognitive development and language. We start out with what? Babies coo and cry. That's what they start out with. And they learn how to get their needs met, and they start to learn how to communicate. And that's all about cognitive development. Moral development, Kohlberg, is about right and wrong. And then understanding, do I do this or don't I do this? And then the school age children they want to please. They want to do everything right. So Kohlberg is all about good and bad and consequence for each. Now, children, what do? They played. They could play. They played 24 hours a day if they weren't sleeping, right? They love to look at things, crawl, put things in their mouth, look at things, rip things apart, throw them, make a mess, right? And there's all different sort of plays, and all these plays mean different things. And we're going to be talking about a lot of them again next week when we get to toddlers and preschooler. There's also different, what we call types of play, whether we're looking at somebody play, playing alone, playing next to someone, or playing the same thing next to each other. And then there's that cooperative where let's play a board game together with an outcome. So now there's an outcome to it, as in let's play a board game, let's play some checkers. So again, we'll go into that more. You know, play is so important. It really helps them with understanding. It also helps them with their development. It's cognitively aware. They understand if they have a truck as wheels, they can roll it and they can make noises. And, you know, it does create them also to help them with their motor. Put the toy farther away, they're going to crawl to it. So it helps with muscle development, et cetera, et cetera. And I love this, that it says an opportunity to bring children and parents together, because the mother will be there shaking a rattle or putting something there, and the kid goes over and tries to get it, and they're laughing and the cooing. It's wonderful. So we get a child, whether it's into the doctor's office or any sort of emergency type area, you know, we're going to be doing some sort of assessment, figuring out, are they where they should be? Now, if they're on just a regular healthy checkup, they'll do more in depth. But even in an emergency room, we're going to be looking at, you know, what we're seeing, because sometimes it's that emergency room nurse who finds those deficiencies and saying, hey, doc, we need to do something here for this kid. So it could be following directions, seeing if they're listening. And again, each child is different. The biggest thing about doing any assessment on any age child is get on their developmental level. Okay, you're not going to go into a toddler and think you're going to go in there and immediately take a blood pressure. Oh, it's not going to happen. Get on their level, create some communication with them, you know, let them touch and feel the stuff. Maybe take your blood pressure first, then they can take their blood pressure. But again, assessments are important. You know, we're going to go into a lot more of these, but, you know, children are born with all different congenital abnormalities, whether it's missing an arm, a leg, a foot, a bone, or being born with a syndrome. I mean, you think of a syndrome, you think Down syndrome, right? Probably the one thing that you might think of. It could be due to intoxication, due to drugs that the parent's on, so the mother. So remember, the nurse, when looking at these sort of things, you know, she's going to be involved in not only getting the tests and examinations done for the genetics, but also realizing that her nursing care must be geared towards that child. If it's a 2-year-old child with Downs, you're going to treat that child different than a 2-year-old without Downs. So making sure that we treat them right. Also, it has to do with, does that child have all the things they need to be the best they can be? Are they in therapies? Do the parents know about it? Do they need some sort of equipment at home? Do they need teaching? All of this stuff, you know, pediatric nurses do a lot more than just nursing care. They're doing more teaching, I think, than any other level. And it's to the parent and it's to the child. You know, there's, as I said, all disorders and all different things that can affect children, you know, and it could be chromosomes. And again, making sure what it is and then treating them properly. Again, role of the nurse, where, you know, these in between, you know, the child, the parent, and the physician, and it's making sure that they get the education, the support. It's also parents who have a child that's born, let's say a cleft lip or with a syndrome, you know, making them understand, you know, it's not their fault. They are feeling guilty, and helping that child and that parent bond as a newborn. Sometimes will be you that starts that whole process. So being aware that, you know, parents do feel guilty sometimes, that, you know, how did I do this to my child? So a child tells the nurse that his child is filling up with house with collections, seashells, bottle caps, baseball cards, pennies. The nurse should notice and recognize this as what? Now, These are different things. Object permanence, I'm going to go to the next slide. I don't want an answer. Pre-operational, concrete operational. These are Piaget and cognitive thoughts. And then these abstract symbols. So object permanence. You know, as a child gets older, even newborns getting to be a couple months old, they saw a rattle in their play area and it gets hidden. They know the rattle's still there, even if though they can't see it. You take a toy and put it away on an older child, put it in a toy box, the kid knows it's not gone. Just go to the toy box, pick it out and get it, right? That's object permanence. Even though they can't see it, they know it's still there. So pre-operational and concrete operational, again, it's that building of cognitive awareness and being able to communicate and using being smart and getting smarter. Okay. And history physical. So when we're working with any patient, remember always to worry about HIPAA, okay? And not talking in front of other people. And they're getting really, really more and more worried about this and making sure that we are being as careful as possible. I mean, we have all of these mobile computers now, making sure they're turned off when we leave the room so that they can't go in and look at anybody else. You know, talking with parents, you think it's going to be easy, right? Well, sometimes it's not. Sometimes you got to get them to talk. Remember, cultures, sometimes they don't want to. And then sometimes you get this child in who's 4 years old and they want to tell you every little thing that happened from birth all the way up to 4 years old. And at 2 months, they had an ear infection and they took 7 days of amoxicillin. And at 6 months, they only weighed this many pounds. We had to increase the formula. You don't need to know all that. You just need to know what sort of delivery it was. You know, did they spend time in the ICU? And then we need to know what's going on this visit. Why are you here now? And understanding and being empathetic. And how do I explain empathy? Well, you've got a little baby, 6 months old, who's sick, been sick for 3 days. They've been to the doctor's office twice. They finally came to the ER because they don't know what to do. The doctor doesn't know what to do. This mother's working as a 6-month-old baby. She's exhausted. So I have to look at the mother and say, you must be exhausted. Wow. You've been to the doctor's twice. You're working. Have you slept? I says, well, you're here now. Let's see what we can do to help you. Because I said that to that parent, all of a sudden you're going to see them relax. They're like, this nurse understands. I've been going through a lot. Okay, she's going to help me. And it does make a difference. And remember, as you're sitting there and you're talking now to this parent, sometimes just be quiet, just listen, and then just redirect if you need to. And if you do not speak the language, do not use a family member. Always use an interpreter or the blue phone, okay? Because the family member is going to interpret the way they understand it, not the exact words that the parent or the child is trying to tell you. With kids, there's all ways that we can talk to them. We could talk to them, you know, by playing games. We could talk to them, word games. We can, you know, have them point to different things on their body, etc. Play is always the best way. But remember, get on the developmental level of the child, and play works on the younger kids. And it really helps them to feel comfortable with you. If you have a group of people in the room with you for a child, number one, get on their level and find out, who am I talking to? Remember I told you earlier, find out who's talking to me, who's going to tell me what I need to know, or 6 people are going to talk to you at the same time. Find out what's going on, what's the problem. Again, do the history, the normal things, allergies, immunizations, any medications today. If they're being admitted, you want to know if they have habits, a special blanket, you know, maybe a special pacifier, special toy. As they get older, you know, an adolescent, sexual histories, There's ways to speak to adolescents. We'll go into that. And then as we're doing this history, we're going to find out, what is that family structure? Is it the father that you speak to, the mother? Is it the grandmother? And then we can figure out how we can communicate the best. I always like to know how a kid's doing at school. The kid will do you at school, that they're going to be adjusted. And you're also going to see during this history taken about these parent-child relationships. I can't tell you how many times I walk into a room with a child and the mother and the father are sitting there watching TV or on their phones. The kid's on the stretcher with every glove out of the box, gauze around, tongue depressors thrown, sheet off the bed, and the parents are not paying attention. And I'm like, did you see what's going on here? And it's, that they have no control over that child. So we have to pull it back to, let's get this kid taken care of. Remember, when we're doing an assessment on a child, we don't do head to toe. It ain't going to work that way. You do what you can do when you can do it. If an infant's sleeping, you're going to listen to their heart and their breath sound while they're sleeping, right? And maybe later on, you might do the eyes or pulses or blood pressure. But again, if you do it as you can, that's the difference. History again, dietary. Always know what their restrictions are, and again, are they nourished, not nourished? Again, doing that height and weight, we can tell a lot. Is there a metabolic problem going on, or they're not being fed right? What's going on? Again, as I said, head to toe is not for children, it's for adults. And always with children, get on their level. Start talking about, hey man, that Batman shirt's really cool, or wow, you got the prettiest blue eyes, or where'd you get those eyelashes from, or wow, your sneakers got light on them. Do something, catch them from another angle. Or how you doing at school? What's your favorite subject? You like science or you like math? Do you like to write? I mean, get them somewhere else. And then you could sit there and get that child prepared, let them practice on you, practice on their teddy bear, whatever, and you're going to get a better assessment taking a little bit of time doing that. Again, looking at all the measurements, remember, all of these are going to be different according to the age of the child. We do apical pulses on the smaller children. It's more accurate. When can you do an radial pulse versus an apical pulse? And again, when you're looking at children, their sizes of the blood pressure cuff are all different for all different ages. Again, looking at all of these things, it's when you can. And looking, sometimes it's just visualizing, like the abdomen. First look at it before you listen or palpate to it. And genitalia, sometimes you have ambiguous genitalia, or you might have fused labias where they're almost closed shut. So you're going to see all different things. Reflexes, have them help you with them. I say, I bet I can make your knee move. Even on the 10-year-olds, they think it's fun. And maybe you let them do it to you too, if you want, right? Head, chest, abdominal circumference. We know at birth, their heads are huge, right? And their chests are smaller. By about 1.5 years, they should be equal or the chest bigger. Try to get a height on a 2-year-old thinking that thing's gonna come down and bop in their head. Let me tell you, it can be difficult. I usually will tell them, let me see what number I am. And I'll say, oh, I'm a number 7. Let's see what you can be. Here, tell me when it touches the top of your head. I go, oh, look, you got a better number than me, whether it is or isn't. And now we've made it fun. And now we've done an accurate height on these children. They think that thing's going to come down and bop them and hurt them. Again, all different size blood pressure cuffs, from 0 to extra large adults. I find doing the last one, D, on toddlers, preschoolers, is the best blood pressure. The arm hurts on the kids. It hurts me. So I know it hurts them. And I find I get better results there. The only time I'd have to do it in 4 places is on a cardiac child. And then the last subject for today is pain. Pain is something that we've just really started to look at really carefully. We think kids don't really get pain, or just a little bit of medicine will work, but that's not true. Kids hurt. And if a kid only remembers, I went to a hospital, I'm in pain, what do you think they're going to think next time they go to the hospital? Oh, I'm going to go to the hospital, I'm going to hurt again. So make sure that they're medicated appropriately. Believe it or not, morphine is a very safe drug to use on these children. 0.05 to 0.1 milligram per kilogram, given it IV very slowly in a diluted mix. You can watch these children just relax, and having a kid with acute abdominal pain, post-op, let's say ruptured appendix, they hurt, post-op cardiac surgery, making sure that we give it as we need it. Find out they have pain, do the intervention, and remember, it's just not medication. Maybe it's giving them their teddy bear to hold their tummy. Maybe it's elevating the head of the bed, positioning, hot pack, cold pack, music. Music helps a lot. The cardiac kid loves music. So how do you evaluate pain on children? Well, there's 3 that we use the most. The Wong's-Baker FACES is one of the big ones, and numeric is one of them. And then the other one is FLAC. Now, when we talk about FACES is only used for preschoolers and older. Preschoolers are ages 3, 4, 5. So a 2-year-old is going to be using the FLAC. Now, what is a FLAC? Well, a FLAC is a nonverbal child. It could be an 18-year-old cerebral palsy child who can't speak, right? What we're going to see is their facial expression. Are they grimacing? Their legs, are they moving it up and down? Are they moving or not? Are they stiff? They can't move. Are they crying? And can you console them? FLAC, FLACC. Okay, that's used for nonverbal and for your infants. Preschoolers up to the age of 8 uses the FACES scale. And it's a pretty picture, little faces. If this is 0, right, as you do adults to 10, what's your level of pain? The book, now I'm not saying I haven't used it for 4 or 5-year-olds, you can, but the book says 8-year-old and up, you can use a numeric scale. And they can tell you a number, how much they hurt. And when they tell you, it's like, I'm a 6. Children who tell you they have pain are giving you real pain. They do it better than adults. Adults exaggerate the pain. Children will be exacting. And I love this about kids. Pain, when do they have it? I think one of the biggest one is ear infections. They really hurt. So the first thing I do when I say to the kid, where's your pain? And they take the hand on the other side. They don't go right, they go the other side. And they say the ear, and I'll give them Motrin, the ibuprofen, for pain. First thing I do, because I know they hurt, and it helps. And actually, ibuprofen for ears helps the best because a little bit of anti-inflammatory in there, right? And isn't that all inflamed with infection? We know that surgical procedures, headaches, braces, all of these things, even children fall down. Their wrists, you're breaking a wrist, whether it's radial or ulnar or both. Make sure that we do medicate them for pain. Again, there's that nice little FACES scale, and I had one right on my badge. I'm saying, okay, which one do you like? Which one is you? And they're really good about doing it. There's all sorts of pain. It could be chronic, recurrent, persistent, kids with chronic pain. How about rheumatoid arthritis? How about juvenile idiopathic arthritis? How about, a child with Crohn's disease, anything, sickle cell disease? All of these things are chronic. Reoccurring, it could be those ears, persistent. All different pains. Make sure that we do something to help them. Because if we don't take care of the pain, that's all they're going to know is pain. And it does affect physical, emotional, social, and school functioning. So getting them pain under control is one of the things that we've been working on a lot. As I said, there are pain things for special populations. There's different checklists. Every hospital has different ones. I would look for them. And again, it's just not medicine. It's other stuff. Now, this little premature baby is doing, kangaroo care. It's on skin to skin. I have seen little babies like this. That's probably about 750 grams there, probably a 28-weeker, looks something like that. And that kid in the isolate and the kid's moving and heart rate up and down and just they're nothing. Put them on mommy, heart rate goes down, blood pressure goes down, respiratory rate goes down, they get the best sleep ever. And it's like almost instant. So kangaroo care, positioning, distraction on children, give them a game to play, give them music, give them, something, cards, stickers. Distraction is one of the biggest things we use. And infants, a non-nutritive sucking, a pacifier. Do you know a pacifier with a drop of sugar water, put it in an infant mouth, newborn, you could do a circumcision on it. And Harvard neurophysiologist said it works as good as morphine. So sucking, self-soothing, pacifiers work. And then of course, remember there's acetaminophen and ibuprofen. You don't have to go right to morphine, okay? And of course, all of the other things that we can use, hot packs, cold packs, positioning. This girl's getting her blood drawn and she's smiling. Why? She's got Emla cream. It's a numbing cream there. She knows she's going to feel touch and no pain. She probably had it done before. Isn't that a better thing than the kid screaming and yelling? You have to hold them down with 6 people to get blood. I mean, I have never had to do that on any age child, unless they had autism or other things going on. But a kid, you can talk with them. You can stop the pain and you can let them understand. And when they work with you, it works the best. Teething, circumcisions, post-op pain, burn pain, all of these things children get. Headaches, sickle cell, you know that. And then of course, there are children that are end of life. And I wish that every kid lived. But I'm going to tell you from the beginning of pediatrics, it's not that every child lives. It's what you gave that child and family while they were alive. Because I have made lifelong friends of parents of children who died on me. But because I did those little extras, those parents never forget me. Every Nurses Week, you should see my Facebook. From Christopher's favorite nurse. Happy Nurses Week. We love you. And this is going back 15 years ago, 20 years ago. So it makes a difference. So which of the following is an important factor for consideration and understanding the pain experienced in children? And you may not understand this. Somebody guess. What did you say? It is. They're not going to tell you. You know why? They don't want the medicine, or they don't want to be stuck with a needle. They're afraid of it. So they're crying. Oh, you're in pain, no. And they are, but they don't want the medicine because maybe what they had at home tastes terrible, or they didn't want to be pinched. They didn't want that shot. Okay. So they do not admit. So absolutely. Very good. You did good there. All right. First lecture. How you doing? Let's go quick and let's go to your Kahoots. Now, has anybody done Kahoots before? You go to Kahoot.it on your cell phones. And you keep this on here. And when you go to Kahoot.it, you're going to put in the number 1074970. And I'll start seeing your names coming up. Now, I also send these to you also with the recording, so you can go back and redo them if you want to. I tell you, you'll find a lot of concepts you need for exams, quizzes, and HESI on these Kahoots. I spent a lot of time getting them done for you. All right, let's get going so we can get out of here at a decent time.
Mine froze. I don't know why.
From a worldwide perspective, infant mortality in the United States. That means the amount of infants in the United States, according to everywhere else in the world. Is it good? Is it bad? What is it? And actually, the best country is actually Sweden or Norway. It is, mortality is higher here than many other countries. We are lagging behind prenatal care, in infant care. We're working on it, but we're not there yet, believe it or not. And you'd expect differently, you really would. The leading cause of death from unintentional injuries in children is it is motor vehicle fatalities, and it's whether they're in the car seat, not in a car seat, or rolled over by a car. I've seen many children rolled over by a car, by the mother, the father, the aunt, the next door neighbor. So it happens. It's a reality. Which statement is most descriptive of the pediatric family-centered care? What does it mean? So the family is the constant in their life. All they know is family. They don't know other people and the way other people things do, which means if you need something from that child, get on their level, their developmental level, explain what you need. Kids do want to please. Just got to let them know what you need to do. The major cause of death for children older than 1 year is what? And it's unintentional injuries. I mean, these are kids that don't know what they're doing, jumping off the couch onto the floor, they break their neck, going up, and I've seen it, climb up a dresser, pull a TV off, land on their head. I've seen these things, and it's unintentional, but it happens. The nursing care for a child in pain understands that distraction. You have a child in pain. What does distraction do? Here's some stickers. Come here. Let's play some video games. Here, you want a movie on TV? Oh, let's play some music. I mean, all different things. We know that it has to be something that they understand. Okay, you infant, put on some music, or maybe reposition them or give them a pacifier. Okay, a toddler, maybe it's giving them a toy, something to play with. Distraction works, and it works well. And what type of
She just put a message in Canvas that she had a power cut and she's coming back on. Oh, and she's here.
That was crazy. Can you all hear me? Power all of a sudden cut and I went blank. Thank you for staying around. Let's see if it's where I was. Gonna have to change the PIN code. And I'm just gonna go forward. I apologize. Having a storm. All right, I'm just gonna move it ahead. We're gonna get you where we were. You guys are good. You're quick. Here we are, type of play that children engage in similar or identical activity without organization. Now, as I said, there's one that's organized and one that they play the same thing, but there's no goal in the end. I mean, you could sit there and build, toys together. And that would be called associative play. Okay, that means they're playing together, same thing, working together, but there's no goal. Cooperative is when they're playing together and there's a goal, like playing checkers, a board game. Okay, so knowing these games is going to be important. Which statement best describes the process of critical thinking? What is critical thinking? It's that thing they tell you the first day of nursing school you have to know, right? You're like, gee, what does that mean? Well, every day you go to the store and you buy what you need to make a dinner, right? Well, that's critical thinking, isn't it? You know what you have at home, you know what you need, you make it. Critical thinking, purposeful and goal-directed. What is probably the single most important influence on growth at all stages of development? I think you heard that like 3 times today, didn't you? Nutrition, 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 nutrition. Without food, your brain doesn't grow and you're not going to muscular, skeletal movement, nothing's going to be where it needs to be. Frequent developmental assessments are important for which reason? Like, are they turning over? Are they lifting their head? Are they grasping? Are they gaining weight? And if not, what do we need to do, right? They're so important because they do identify those delays, and then we could do what we need quickly because children are so resilient. They'll catch up quick. Which function of play is a major component of play at all ages? What is play all about? And it's sensorimotor. It's that touching things, feeling things in the mouth, because they explore the world through their mouth, and then the movement, which does that cognitive, which is the intellectual development too with it, okay? Sensorimotor activity, very important. 3 children playing a board game would be an example of what play? See if you remember what I said. Cooperative play. Good job. Yes. The head to tail growth of development is referred to. These are different words that you need to understand in pediatrics. Again, you know, look at those words at the front of your chapters because you'll see them again. You know, and if you look at these words and pulling them apart, cephalic is head, right? Cephalocaudal, that's head to tail. They lift their head first. What is the single most important factor to consider when communicating with children? You need to get something done. You go into that child. What do you need to do? What do you need to understand? The child's developmental level. Yes, get on their level, be a kid. I went to work and I played every day. They paid me to play with kids. What 2-year-old child pain assessment tool should the nurse use? 2 years old, which is the one? You know, we talked about FLAC, we talked about faces, and we talked about numeric. Those are the ones that we use a lot. And it's FLAC because faces doesn't start till preschool, ages 3. So a 2-year-old is FLAC. At 6 months, an infant birth weight should do what? I mentioned it once. This is something you're going to see again next week. It's just one of those concepts that we need to know. What if they're not at that weight? What do we do? And what if they're too much? What do we do, right? So interventions are made. Too heavy, too skinny. It should double by 6 months. Very good. You'll hear it again next week. The first fine motor developmental milestone for an infant begins with, well, there's 2 types. Fine motor is all about fingers. Gross motor is all about get up, go, go, go motor. So fine motor is fingers. So the first thing is that reflex palmar, where their hand is out, you put something in it and they grasp it. Then it goes to voluntary, and then it goes into pincer with the finger. First it's really crude, and then it's like the little Cheerios in the mouth, and then we put objects into a container and build a block of 2. These are all fine fingers, what we do with fingers. At 8 months old, an infant should be expected to perform which fine motor skill? So if we went through that reflex palmar, then we went to voluntary palmar, then we went to crude pincer, and then putting it into the containers. It should be getting that grasp the handle and the crude pincer. They don't put things into containers till 11 months, and a block of 2 is 1 year. So these are things in your reading, as you'll see, just to re-emphasize it. Again, we'll go through it next week. The natural physical developmental sequence that most children follow is what? What's the first thing that an infant will do? First thing they do is lift their head. Then they roll from front to back to front, and they get up on their knees and they start to crawl, and then they get up and they creep, and then they walk. Now, this is up to 1 year old. It doesn't matter if they don't get to there by 1 year old, as long as they're moving in a forward progression. My children never walked by 1 year old. They ran at 15 months old. They never had teeth at 1 year old. They got 6 at 15 months old. As long as they're moving forward, they were okay. Which behavior indicates that an infant has developed object permanence? What did I tell you about object permanence? Object permanence is that they know it's there, it's hidden, but they're going to find it. They know they're going to look for it. Even if it's not in sight, they still can find it. In general, an infant should triple their birth weight at how many months of age? Well, we said earlier they double at 6 months. So 1 year old, they should triple. Again, if they were born at 7 pounds and they're 28 pounds at 1 year old, they've quadrupled. They're too much. What do we need to do? Well, maybe they're still on formula. Maybe we need to cut back. Or maybe they're only 12 pounds. We need to increase calories. So these are little milestones that are very important to monitor. Performing a head-to-toe assessment on a toddler, most important to consider before beginning the examination. Now, toddlers are ages 1 to 3. Start with their developmental age. Look at them and then talk to them. Bring them fun. Maybe I always had stickers on my pocket, or they've got the eyes or the freckles or the ponytail or whatever. Mention something and get them that you are not threatening. Because remember, we are threatening. We give shots. According to Piaget, toddlers are in the blank developmental stage. Again, I'm showing you things that you're going to need to know for examinations and quizzes, just bringing to light. Again, we're going to go over this next week, just introducing these things. Again, sensory motor, right? This is all about mouth. This is all about touch, what it feels like, and moving stuff around. Which intervention helps a hospitalized toddler feel a sense of control? I think toddler in a hospital is a very hard age. Their age is 1 to 3. They don't understand what's going on, right? Take a kid this age on vacation and it's also hard, right? Because what? You get them off their schedule and they don't know what's going on. So try to keep them on the same routines. Try, if you can, the same type of foods, same bedtime, same bath time, and they don't feel so discombobulated. They understand what's coming next. That's what toddlers love, that routine. All children reach developmental milestones at the same age. Yes or no? Absolutely not. You know, you'll have some kids walking at 9 months and you have other kids who don't walk to 15 months. And as long as they're moving forward in the sequence of events, they're doing okay. Very good. Immunizations for a 4-month-old infant. Which action should the nurse take to provide atraumatic care for an infant? What can you do so it's not going to hurt? Well, you can use my program, Huggies, right? Hold that infant. Or give them that pacifier with sugar water on it. It works great. Which of the following immunizations can be administered to a newborn? Now, if you open the book and you look at infants for next week, there is a double page of immunizations. Don't go crazy trying to remember them all, okay? Understand that this is the first one that you give, and we know that infants are born with no immune system except what mom's given them. And we know we load them up at 2, 4, 6 months, 15, 18 months. We just load them up against those bad diseases. But hepatitis B is usually given before discharge as a newborn. Normal heart rate for an infant is 140 to 160. Good job. What is the preferred site to give an injection to an infant? This goes back to pharmacology, doesn't it? And it's right in that vastus laterus into that thigh. Again, you can give this injection to the infant as that is being held by the parent, and they do really well. I just have another nurse holding their leg because I don't want them to move. The death of an infant under 1 year old with no known cause. And we're going to talk about this more and what are the risk factors for it next week. But it's SID, sudden infant death syndrome. Very difficult, but we've decreased the amounts of these in the past like 15 years. A Vietnamese mother of a child avoids eye contact with a nurse, considering cultural differences. Why? Again, cultural thing. Like, why isn't she looking at me? It's respect. This is respect in this parent's eyes. A child from Mexico is being hospitalized for a serious illness, and the father says the child's being punished by God. Why is this father saying this? And believe me, you will hear things like this. If you ever work in pediatrics and work with different cultures, you will hear things. And they believe this. They strongly believe this. Which term refers to an individual's life when he or she is more susceptible to positive or negative influences? Again, this is one of those words that I told you you're going to need to understand at the beginning of each chapter just to take a look at it. And that's called sensitive period. They're sensitive to negative or positive influences, right? That makes sense when you think of it that way. What is characteristic of the pre-operational stage of cognitive development? Again, this is Piaget. And there's different stages for different ages. Again, we'll go over it next week. I'm also going to be handing out a handout for you tomorrow, vital signs and one on the theorists, so that you'll have something to look at a little bit more. You know, they only know what they can see and touch and feel. Okay, they don't make any logic of anything. What can they see? What can they touch? This is more of your toddler stage. And last question. According to Kohlberg, children develop moral reasoning. What is a preschooler stage of moral development? What did I tell you Kohlberg talks about? I know I talked about 4 different theorists. and their actions are determined good or bad. And there's a consequence for each. And as they get older, these understanding it changes, but it's all about understanding good and bad things, and that there will be a consequence for them. So good job, guys. Emily, good job, Emily. Number 2. Della, good job, Della. Number 1. Oh, we have Rudolph the Red-Nosed Reindeer. Nicole, good job. And Kayla and Jazz. Good job, guys. So I will be sending you out this information. It's been a pleasure meeting you. Any problems, questions, concerns, please just send me a message. Thank you for being patient when I had my power outage. Thank you, we're all here. And have a good evening, okay? If you need anything, always holler to me. Have a great evening. Take
Bye.
care.